Guys, so I'm just going to try and share my screen now. Hopefully, away we go. Okay, so I know that there'll be a lot of people that have maybe been on the previous talk with that Emma Rickards gave a few weeks back. So apologies if I'm dipping into some of the stuff that's already been previously talked about, but obviously sometimes it just helps to recap what we're looking at. So I'm specifically looking at the treatment of CAP, and obviously avoiding HAPs and other forms of CAP. We will discuss these again in another virtual ward seminar in kind of September, October time. Okay, so the series learning outcomes were obviously to look at diagnosis and management of community-acquired pneumonia, diagnosis and management of complications of community-acquired pneumonia, aspiration pneumonia and other respiratory infections, and obviously the final illness. So today we're going to be looking at this first section, and hopefully we'll shed some light on the others in later series. So obviously, from a community-acquired pneumonia perspective, it's massive. It's the largest cause of mortality in the world. Essentially, 1 in 5 people are going to be affected in England. Rates doubling over the age of 85 in that cohort of people, from 65 to 69 to 85 to 95. There's an increased incidence of areas of social deprivation, and obviously you'll know specifically your area, but obviously here in Knowsley specifically, we do have quite a high level of social deprivation, so unfortunately higher levels of pneumonia. 5 to 12% of adults presenting as a lower respiratory tract infection in primary care end up with a CAP diagnosis. Obviously, there's slightly different mortality rates. Some go even up to 25%, but that's in specific cohorts. You're looking at around about 10%, ideally. The 50% of those deaths, though, are in that older age group. So we were looking before, obviously, the rates get worse in over 85-year-olds, and obviously they're even more at risk of death through CAP. So looking there at the definition, community-acquired pneumonia is a pneumonia acquired outside a hospital, develops in a nursing home as well. That's also included in the definition. And when managing the hospital, we usually confirm this with an X-ray, but sometimes in the community that's not possible. I'm aware of that, but it's an acute disease of the parenchyma and caused by an infection. So sometimes that can be viral, sometimes it can be bacterial, and usually, obviously, acquired outside of the hospital setting. Just a couple of examples, really, of what we're looking at, and sometimes it looks very different on chest X-rays. You'll obviously recognise the typical wedge shaping, but these are slightly different ones. I just thought I'd show you. Obviously, the first one, kind of right upper zone, and then the left one there is more abscess related, so it looks very, very different in the left upper lobe. You can probably see it there. Okay, you've got some small abscesses in the lung itself. It looks very different. Now, this is that same one or similar one in CT form, so it does look very, very different in CT form. Still looking here, the abscesses. So what we're looking for obviously we've got a bit of a mix of people there. You've obviously got hospital based, but in the community, you're looking essentially for somebody with cough, shortness of breath, that typical pleuritic chest pain. It's rubbing, it's getting harder when you're doing a nice deep breath. They're absolutely shattered. They have a temperature, no cause for other symptoms. And then we're looking in the elderly, you're more likely to see confusion, worsening of other health conditions, and sometimes they present with those at hospital, not necessarily symptoms of a CAP. So we just need to be mindful of that in that cohort of patients. So chest symptoms, cough, whether or not they've got sputum, the pleuritic chest pain, shortness of breath. Looking specifically when on examination, those bronchial breath sounds, reduced air entry. Sometimes you'll get crackles if it's not fully consolidated, and then decreased chest expansion. So you'll really feel that when you get hands-on. Obviously, very dull to percussion. Systemically, temperature. Sometimes they'll have chills or rigors, sometimes they won't. the biggest one really is that they just feel absolutely shattered. Now, you'll obviously get a lot of those symptoms with a few different pathologies. So it's really somebody that's coming across with no other kind of previous comorbidity that would link to these symptoms. And that's where we're kind of thinking potentially CAP. Obviously, there's lots of different guidelines out there specifically, but you will have your own pneumonia guidelines locally, and also that antimicrobial guidelines locally. We've got Pan-Mersey guidelines. I'm not sure anyone who's over there in Crewe or Leighton, are you guys governed by Pan-Mersey guidelines that far across? Anybody?
No, I don't think so.
No, I don't think we are. No.
No, so you will have your own, obviously, your own area antimicrobial guidelines that you need to be looking back at and making sure that you're following. But obviously, those over this way, the Sefton Crew, I think, are you governed by Pan-Mersey? Sure.
Yeah, Carol, at Leighton, we do definitely have our own because they've printed out onto the doctor's trolleys.
Oh,
Yeah.
right, yeah.
So you will have your own, but obviously you just need to be mindful of those. And I would suggest a little bit of homework from today if you're not really au fait with those in your area. Just go and have a little look and see specifically what they are. And obviously you can veer away from these if you've got good reason, but obviously if you're using them as a starting point, it's a great place to be. Okay, I know that these guidelines Emma did go through previously, so I'm not going to bore you with those. But I think most important things really is, are we using appropriate scores to safety net these patients essentially? So there's the pneumonia severity index, and it's obviously looking specifically at demographics, comorbidities, what do we see when we actually see the patient, that imaging side of things. And obviously you won't necessarily have those in the community, so I think we'll show you another score in a second that might be more appropriate. But in the hospital base, obviously you will have access to these other things, and sometimes the PSI is used more commonly. So PIRB 65 is another one that we use in the hospital setting. This is probably the most frequently used severity score, and it looks specifically at 5 different areas. Is the patient confused? Is the urea high? Are the rest rates above 30? Are they systolically underfilled and diastolically underfilled? Either of those will score you a point. And are they over 65? Will score you a point. Now, we look then at the risk groups based on this, and then we can look at appropriate management for the patients. So from a virtual ward perspective, we would be happy to be accepting somebody 0 to 1. Okay, now sometimes in this, that might not fit the picture. So somebody might be scoring a 2 in the community, and we can support with that. We might be able to manage that, but that would be discussed on a case by case basis, and it just takes a phone call to the clinician on call that day, and then we'd obviously recommend. Often it'll be somebody that doesn't want to go in, who's been recommended by the teams in the community to go into hospital, but they're just not going in. Okay, but often that group, that score of 2, are likely to need an admission, and then when we're going to 3 to 5, you're looking more admit and possibly even ITU admission from that perspective. Obviously in the community we don't always have access to urea. Sometimes some teams have got point of contact testing. It's something that we're looking at in Knowsley at the moment regarding trying to see if that's a possibility, if it's feasible to do kind of point of contact testing for urea and other LFTs and other things using these, but that's not the case at the moment. So again, from the CRB, slightly different because we're missing urea, but essentially the rest are the same and a similar situation. Okay, looking at 1 to 2, that's the only difference. 1 to 2 in this are likely needing hospital admission. Okay, but again, they can be discussed on a case by case basis. Okay. Now, pros and cons of the two. So obviously, PSI takes into account the comorbidities. whereas this CORB that's not the case. It's more accurate at predicting 30-day mortality, and it defines a greater proportion of patients at kind of a low risk of mortality. So that might be more appropriate for those that we're trying to discharge and turn around in A&E with virtual wards, for example. And it's a higher discriminating power of short-term mortality. So that might be able to indicate escalation and further examination required sooner. But that is heavily weighted by age. So if you've got a very healthy 85-year-old, obviously that might predict their mortality slightly higher than you'd expect based on the comorbidities. From a CORB 65, you're looking at, it is a true severity index, so it's known, and that's what it was made for. It's easier to use, much easier to use, and it is known to be accurately predicting 30-day mortality. However, unlike the PSI, it doesn't account for comorbidity, so you are missing, and you need to be using clinical judgment based on patients' comorbidities and past history. Have they been admitted previously? You know, have they had previous pneumonia? All that sort of things really as to how at risk they are. So from a treatment perspective, what are we expected to do? So kind of most important thing is that we're using those tools to guide our clinical kind of judgment. We've got to get an early sputum sample if they're productive. I appreciate not every pneumonia is productive. Completing an ABG in the community if that's necessary, if it's appropriate, especially if somebody's saying they don't want to come in. Sometimes that can give you a bit of clout to kind of support them with their decision-making process around whether they should or shouldn't go in. Sometimes that's probes fib a little bit, and once they start going below 90, obviously not as accurate. Most importantly, educate. It's massively important to avoid unnecessary contact. So later on down the line, if they know what to expect, they're less likely to be in contact unnecessarily with primary care services. It's really important. Gaining a thorough history so that we can make those appropriate decisions. We've all got that history, and there's a lot of well qualified staff on the call at the moment, and that's great. So good thorough history of patient's background, and obviously if you're not the decision maker and you're passing it on to somebody else, this is great. So if you can get a really thorough history and let patients know what to expect, it's fantastic, because the next clinician that's coming or the medic that's coming to make those decisions has got a lot of the background information, especially if they've got other respiratory conditions, COPD, bronchiectasis. It's nice for them to know what is their current management, kind of how unsettled are they, how often are they in and out of hospital, if they're on oxygen at home, is it LTOT, is it ambulatory. Really important, because often we'll get patients come in diagnosed with a CAP, sent home on 2 litres because they've told the doctors that they're on 2 litres at home, but it's actually ambulatory and they've sent them home on LTOT. So it does happen, so we just need to be mindful of that and make sure, and it's good if we can document that in the notes if we're aware of that, if we're community services, so that staff know. Obviously, consider sepsis. Whenever an acutely unwell person presents with a likely infection, think sepsis. Pneumonia is the main cause of sepsis, so we just need to be aware of that and appropriately bleep the sepsis nursing team to come out and have a look. Yeah, are they optimised? So from our perspective, are they using inhaled therapy? Is that appropriate? Can they use it effectively? Have they got a good inhaler technique? Is the device that they're using appropriate? Do they look like they've got good enough inspiratory effort, for example, especially on the dry powders? Because a lot of the times, people don't necessarily get reviewed as often as they should with their inhaler technique, and as they age, they struggle then to get the inspiratory effort for those. And naturally, we're picking them more readily now for obviously the lower CO2 emissions, but at the end of the day, moving forwards, people are going to age, so that will change, and their ability to use that medication is going to reduce. Obviously, consider a chest X-ray. If we're out in the community, you don't have to do an X-ray. Ideally, we would want you to, especially if they were higher, CRB of 1 or 2. Definitely suggest getting an outpatient X-ray, and obviously if that confirms CAP, then we can continue with the treatment. Is the patient suitable for onboarding to the respiratory ward is the main thing, really. do they look like they're somebody that could manage the equipment? Are they somebody who would comply with the equipment and the treatment? Is there anybody around? If not, we try not to discriminate against anybody and support them as much as we can. And if they can't necessarily use all the equipment, sometimes if they don't want to go in, we just give them SATS probe and a blood pressure cuff. You know, if they don't want to particularly have to put it in, we can sometimes get telehealth to give them a call once a day to get the readings directly from the patient. Or it might be that family members can only come in after work once a day, and they will be able to obviously look at trying to get those numbers into telehealth once a day, which is helpful. Okay, from an education perspective, the most important we can do is prepare those patients, because people don't recognise that CAP and LRTI are not the same thing. Often they will say, "Well, I've been on the antibiotics now for 5 days, and I'm not any better. You know, don't feel that much better, and kind of I'm still shattered and I'm still coughing." And it's absolutely normal. We'd expect that, really. So to be able to educate them around what is expected and how long it's going to take for that to resolve, advising them for rest, good hydration. Obviously, if they're a smoker, really imploring them to quit, at least during this process of illness, because that's going to be the best thing for their chest. And longer term, if you've managed to get them off for a few days, link them in if they're amenable to a smoking cessation team. Obviously, there's the very brief advice training online, and obviously now most mandatory training has very brief advice as part of it, so you've probably already experienced it. But if you haven't, there are free courses online that you can just load yourself up to, which is great, because then it also goes to the next level from very brief advice. And obviously, if you want to do it, that's fantastic. Educate them on what to expect. So after a week, we expect them to not feel red hot anymore. After 4 weeks, we're expecting that kind of chest pain, that pleuritic chest pain, and the sputum production should have substantially reduced, and if not started to resolve. Cough and breathlessness should have reduced again by about the 6-week mark, but it still will remain, okay? And that most symptoms should have resolved, but they still might feel tired at 3 months. But the one that holds on the most is cough and fatigue, and to explain that it might take up to 6 months to a fully resolved, and that's if nothing else has happened in the meantime. So if they've been absolutely well within that time frame, that's great. Within 6 months, we're looking at, you know, you should have fully resolved and feeling a lot more like yourself. But if they've in that time period, if they've got a comorbidity, or if the diabetes has been poorly controlled, or if they've had something else exacerbate, or they've got a viral illness in the middle of it all, then that can also take a little bit longer to resolve. So early introduction of antibiotics. So obviously, if you're out and about in the community and somebody's very unwell, the aim is just to get them straight into hospital, and they will commence antibiotics if suspected sepsis within an hour. Usually these will be IV, and if high risk, the same IV. If we're not sure and that, you know, they're unwell, but we're not thinking sepsis, then usually again targets are within 4 hours to have some antibiotics, whether that be oral or IV, and to be gaining sputum sample, so that if that comes back, or if they've had one previously, if they've been unwell, for example, in the community, and you managed to get one a few days earlier, you might have that sputum sample back and ensure that you narrow the spectrum based on that sputum result, to narrow spectrum antibiotics to appropriately treat the patient. So from an antibiotic perspective, you're looking at 24-hourly review of the route, IV versus oral. Obviously, they'll look to see, are you responding appropriately to the IV? You know, are you bettering yourself? Are you eating and drinking fine? And if that's the case, drop you down to orals, and they'll try and get that done as soon as possible. They'll look to, there's differing advice from slightly different guidelines. So some say 5, and our local guidelines actually say 7 for moderate and high. But I think the national guidelines say 5 for all. So I think it just depends on being driven by your local area. may also indicate which type of organism, and then therefore which is the most appropriate antibiotic. If there's a flare up at the time of a specific organism, they might choose to go for something different, or if somebody's particularly unwell, they'll head that way as well. Obviously, in different types of bacteria, they may look to treat for much longer. So Legionella, Staphylococcal, gram-negative, they sometimes do 2 to 3 weeks of treatment. And obviously, if somebody's bronchiectatic, same again, you might be looking at a longer course of 2 weeks in those, or 10 days, depending on your local area guidance. So our one in Pan Mersey looks for, if we're low risk, so CRB 65 of 0, we can start with amoxicillin, clarithromycin if penicillin allergic, or doxy, 200 milligrams the first day, and then 100 milligrams for 5 days in total. But again, your local area, I can't employ you enough to go and have a look at your own area, because it will be different. I've just come from Manchester, and it was the reverse in Manchester. So doxy was first line and amox was second. So yeah, have a little look and make sure that you're following your local guidelines. If they're kind of 1 to 2, we're looking at the same amoxicillin, but again looking 7 days, so slightly longer, and Clarith or doxy. Okay, so things would change a little bit if somebody was penicillin allergic, and then again, we're not going to look too much into this, but if there were risk of aspiration, so a lot of your nursing home patients, if they've got an experience of choking episode, or they're coughing with eating and drinking, there's a good chance, or they've got poor swallow, or they're on thickened fluids, or they've got any sort of compromise to the swallow, definitely be heading down this route first. Coamoxiclav TDS for 7 days, or adding in metronidazole, depending on if you've got samples. So when to escalate? So if somebody's out in the community and their symptoms kind of worsen rapidly or significantly, or they don't start to improve within 3 days, or they're not improving as you'd expect them to, or they all of a sudden become quite systemically unwell, so they lose hemodynamic control, they could become tachycardic, hypovolemic. So yeah, we kind of worry about those sorts of patients, and it does happen even on the virtual ward. Even with treatment and optimal therapy, and they've been seen by community teams, they'll still potentially deteriorate, and it often will be because of some other cause. So something else might be bringing it on. So they've been diagnosed with a CAP, but they've got underlying asthma, and then the asthma flares up. So it usually is something like that ends up sending them in. So from a discharge perspective, okay, in the community, in the hospital, we'd be looking at not routinely discharging patients with CAP if in the last 24 hours they've had 2 or more of the following. So have they had a temperature higher than 37.5, a respiratory rate of 25 breaths per minute or more, heart rate over 100 beats, systolic blood pressure of 90 or less, oxygen saturations under 90% on room air, abnormal mental status, or an inability to eat without assistance. So of those that are in the hospitals, like, how do you feel about that? What does that make you think when you're looking at that? Because it's making me think, and I work in the hospital base. There was a group from ITU. What are your thoughts on that one for a safe discharge? So for me,
I think it's just dependent on the patient as well.
Yeah, definitely.
Like your respiration rate, and a lot of our COPD patients are a lot higher. Yeah, I think it's just case from case, really, isn't it?
I think definitely, because I know of a lot in the last week that I've been to see that sit quite happily with, you know, heart rate around 100, and are known to have a respiratory rate of around 24 as a normal for them. And, you know, they wouldn't, and saturating at 88% because the type 2 respiratory failure. That does that mean they can never go home? It's not the case, but I think it's a great starting point. For you to just be thinking, you know, is this going to be a safe discharge? Am I concerned? And if that is the case, is this somebody that we can maybe expedite sooner using the virtual ward as a backup? So these are the ones that you need to be thinking, actually, yeah, we probably could discharge them still on optimal treatment, but onboard them to the virtual ward so that they've got another 7 days of monitoring, or, you know, as long as they need really, but usually 7 days. These are the ones, the targets that we're trying to get them out sooner, rather than, you know, rather than staying for another couple of days until those equalize. And specifically, British Thoracic Society say, consider delaying the discharge for patients with community-acquired pneumonia if their temperature is higher than 37.5. So specifically just on that one. So even though they said 2 or more of the following findings, they think that the temperature is one of the most important ones. And if it's been raised once or twice within that last 24 hours, to delay that discharge. So in summary, kind of treatment, 5 to 7 days, maybe longer in certain cases. Switch them early to oral as clinically indicated. Discharge them when they're afebrile and they're hemodynamically stable for 48 hours. And if they've failed to improve within the 48 hours to 72 hours, we would indicate that we'd be looking there to have an extensive workup. So that's when we're expecting the bloods, we're expecting them to be going to have, you know, possibly gram staining, kind of further chest x-ray potentially, and then review bloods and see what else we need to be doing. Do we need to be changing them antibiotics? Is there something else that we're suspecting? Is there a Legionella or chlamydia or something else that's making this pneumonia worse than we would expect? Is there now cavitating abscesses? You know, do they need a CT to look into that? What else can we be adding in, really, essentially? Kind of in terms of thinking now, those that are in groups or those that are on their own, have a little think now. So if we're out in the community and you have a patient who is previously known to have been admitted with a pneumonia, they are currently using a 3, and that's on respiratory rate and low SATs. Okay, and they've been on treatment for 2 days, and treatment as just LRTI, so they're just on amoxicillin. What would we be looking to do with that type of patient? Trying to get back, bear with me 1 second. I'm just trying to get back to the teams. There we are. Do you want to just pop your cameras back on, just so that I can see everybody again? So those that are on Nicola Willman's group, if you guys are you're in the hospital base, aren't you? All right.
No, we're both, because we do community, hospital at home, and early support of discharge.
Okay, so with that sort of patient, what would you be thinking of doing based on that CURB, and the what we've just mentioned there? So if saturating a little bit lower than expected, but still kind of acceptable levels, but you know, not ideal. They've been on treatment for a couple of days.
I think, well, we'd be considering what's on chest exam, and if we hadn't already sent a sputum, possibly think of a chest x-ray, depending on their full assessment.
Yeah.
Yeah, possibly we can access chest physio if needed.
Okay, so has anyone else got access to chest physio, just by a quick way of hands? in your areas? Have you all got chest physios that you can call upon in the community? Not really.
No.
So I think it's really important, like Nicola said there, to get hold of the right people at the right time. So if they're struggling to expectorate, for example, the chest physios are great. They can get out there. We can get saline nebs involved. They can do VIBs. They can do some bubble pep. They can do breathing control and helping them to expectorate appropriately. And that can avoid an admission potentially, because somebody can start coughing it up quicker. And obviously it helps them to feel a lot better, helps them feel less breathless, more in control, less anxious. So anxiety can often lead to a hospital admission just based on the fact they can't clear the sputum. So it's really important that we get the right people in the right time. Yeah, she mentioned chest x-ray. Does everybody have access to community x-ray?
We do, but we can't request the x-ray. It has to come via our consultant or the GP.
Okay, fine. So it's getting in very soon with the right people to be able to escalate that. And in terms of kind of blood work, does anybody have access to community phlebotomists? No.
Again, would be through the GP for us.
So it's all through GP based. Okay, fine. So yeah, it's really important that we get that sort of blood work up ASAP. If the saturations are dropping, it is something that if they're dropping below 92, we should be gassing them, keeping an eye, and just making sure that we're giving them the information so that they can make the appropriate decision whether or not they want to go in to hospital or stay at home. If they're planning to stay at home with that patient, what would we be looking to give them in the community? So if you nip back to the slide, if you can remember the slide. So they've been given amoxicillin. They're already on amoxicillin. What else might we want to add in?
Add in Claret with the amoxicillin, or
yeah, Claret or Doxa, yeah, definitely. So we want to be optimizing them as much as possible. But obviously, if in that scenario, would anyone just want them to go in?
It depends on how they're managing at home and if they're dehydrated or pyrexia. Yeah, if they've got a temperature.
Yeah, so I think the most important thing is that we're symptom managing. So with somebody like that, are they taking, you'd be surprised at the amount of people in the community who are sat there feeling hot with rigors and all the rest of it. And then you ask them a simple thing of, have you took paracetamol? And the answer is no. They don't want to take tablets. They don't want to do things like that. So just getting them to take some paracetamol, making sure that they've drank enough to help both from a hydration perspective and obviously a temperature perspective as well. And then if they wanted to stay where they were, you'd done a gas. The gas was actually okay. They're going to stay there. You've put them onto clarithromycin now and added that in, and they're going to go for a community outpatient x-ray. When are we reviewing this patient again?
We would normally review every 24 hours.
Okay.
For our patients that we have at the minute.
Anybody else any different?
Just going back on the gases, we're not yet doing gases.
Yeah, that's fine. That's fine. And it's not available to everybody in the community. So if you haven't got those gases to go off, pulse oximetry, to be honest, is what all the guidelines are saying is the most appropriate to use to monitor somebody. So it is adequate to just use pulse oximetry. It's just that if you've got that support of something else and you're worried about a patient in the community, I know that the Knowsley teams do have that. I'm not sure, does the Sefton team have that ability as well?
No, we haven't.
No. Yeah, so it does help to just give you a bit more of a clinical picture really to work from. Okay, so yeah, 24 hours. The guidelines state 48. So review them again in 48 unless you've got other concerns. So just, that would be okay. And if they're under the virtual ward, we'd usually discuss with the community-based teams and obviously see what the plan was. If they're happy, sometimes they'll leave it for the 48 hours because under the virtual ward they're putting in their observations. We'd escalate that, we'd escalate the concern from that perspective, if they needed to go and see them sooner. So you've got that safety net with the virtual ward, from our perspective, which obviously is reassuring for the patient and obviously for the teams out and about as well. So it's a bit shorter actually than expected. I don't know what's happened with the slides. I had 2 example slides on the bottom and they've flicked off. So in terms of questions, has anybody got any questions now that they want to ask?
Yeah, sorry. I just wanted to ask about the X-ray because I'm not really familiar with the X-rays. So when you put the X-rays up, I didn't know what I was looking for.
They mean nothing. Yeah. So basically, you're looking for a CAP to be diagnosed. You're looking for a kind of a different colour, that white area on the X-rays. Right. So if sometimes it'll be a lovely, perfect little wedge shape, which is giving you, a specific lobe. Sometimes it's more than one lobe. Sometimes you have a complete whiteout on one side. Sometimes you'll have it both sides. And obviously you'll hopefully have a radiology report, but often the medics will just have a little look straight away and they'll see, as soon as they see consolidation. Sometimes you'll get patchy consolidation if you've caught it early enough where it kind of looks a bit fluffy, and you kind of lose the outside borders of the things that you'd normally see. For example, the heart border or the border of the rib cage with the diaphragm. So kind of that lovely angle that you normally get, you kind of get blunting of that and you lose it, so you can't see it anymore. So this is what they're looking at specifically to say, so if that's not present, they haven't got CAP basically. So if you haven't got radiological findings, it's not a CAP, so it will just be LRTI.
So what would a chest infection look like then? As I know, you said, like, is it a CAP or a chest infection, or are they both the same thing?
So you wouldn't necessarily get radiological changes, right, with a chest infection. Right. So if you don't get them, it's more likely to be a chest infection. So if they're productive of pure different coloured sputum, at that point we'd be looking to say, oh yeah, they've got a chest infection, but is this worse than a chest infection? So I think Emma went through previously that with a CAP, that's when essentially inside your lungs you've obviously got your branches, you've got your thinner branches, and then you've got your little, what I call them, grapes at the end, those little air sacs. Now what happens in a pneumonia is those air sacs fill with the stuff inside the body that normally helps to fight an infection. So the white cells get stuck in there and it obviously gets really thick and gooey. Now that's what you can see. That's that white colour on an X-ray. So you can see it because obviously it's trying to then pass the radiation through essentially soup, which it can't do that. And then you get a slightly different colour on a chest X-ray, which is what we're looking for to definitely diagnose pneumonia.
So what would an abscess look like on an X-ray?
So it goes usually a lot more black, and it's kind of got definitive edges that are obviously a lot bigger than the air sac, so you can see it visibly on an X-ray. So if somebody is starting to develop an abscess and you can see that on chest X-ray, that's a very worrying sign. That's somebody that might end up being admitted to ITU, depending on obviously their systemic symptoms and how well they're managing with that. It might just be they get IVs and lots of other antibiotics sent to them, but they're the ones that we'll be wanting to do like samples on and making sure that we've got the pathogen, we know what we're treating so that we're treating them effectively, because they're massive risk of mortality essentially.
Right. So will the CAP leave scarring if you've had it before?
So sometimes, but what they look for is they repeat the X-ray in 6 weeks' time. Yeah. So for anybody who is working in hospital sites, it shouldn't be your responsibility to organise it. It should be, whoever's doing the TTO, whoever's the person in charge who's discharging a patient, they will organise that a repeat CT is done in 6 weeks, and usually they'll come back to a pneumonia clinic for review. So you can just make sure that if you're the person with them and you're talking, you just mention if they're coming back to pneumonia clinic, if they got a repeat X-ray booked in 6 weeks.
Lovely. Definitely. Thank you very much. Thank you.
No problem. Any other questions? Everyone's gone very quiet. Was that what you were expecting? Because I kind of, it was going to be an hour session ideally, but it's obviously a little bit.
Will we get a copy of the slides?
Yeah, so the slides can come out. Not a problem. I'll pass them on to Claire and get Claire to email them out to everybody. That's not a problem. Yeah. And I think really the other thing that I could maybe add in is a lot of links and things to the guidelines, just so that people can have a read of the guidelines themselves. Because you tend to lose people a little bit, and they often get this nicer, succinct versions of the guidelines for those people who you know find it a bit hard and a bit slogging to read right through, that we can obviously send out, and they're very helpful, very useful to guide people's kind of treatment. I think the most important is basics, that I can't stress it enough, that the treatment of CAP is not just based on antibiotics. It is about all the other things that make somebody feel unwell. You know, for those people that are seeing them, it's getting hands-on. What does the chest feel like? What does it sound like? What is worrying? What am I concerned about? You know, what sort of symptoms are they improving? If they're not improving, escalate it. Make sure that further things are done, further examinations are done. If somebody is improving, there is no need for repeat CT in hospital, CT or chest X-ray in hospital at all. We should just be seeing those patients through and sending them home. And obviously, if there's still some concerning signs, like we discussed before, with, you know, have they had a bit of a temp spike, or was their CRP really raised? So we've had lots of people now who have gone home and the CRP in hospital was like 450, and then it's come down to 260, which is a little bit above what we'd normally accept on the virtual ward. But if they've had 2 or 3 bloods in between and their trend is coming down, we'd probably be happy to accept those patients as long as the white cells are below 20 and they're you know feeling better in themselves. But it's just to be mindful that there are other things that we can be monitoring them with, and it's looking at the whole picture. But clinical judgment, and in every single one of the guidelines, it's clearly stated that your clinical judgment about how well this patient is above everything. So you might know the patient, especially if you're in a community team, you know what their normal symptoms are like, and this is nothing like what they normally present with. They might have background of COPD, or you've had them before with bronchiectasis, and it never seems to clear up even with the 2 weeks. You know, they tend to grow atypical bugs. Have they had previous Pseudomonas, for example? You know, do they have Legionella in the urine? Like, looking at these other things, what else could it be? Don't just let somebody kind of take. We had one a couple of weeks back, actually. He was on the virtual ward, and he'd been kind of just very, very samey for a long, like a good few days, really, and we kind of couldn't put our finger on what was going on because they just seemed to be very samey. I think chest physio went out in the end and actually saw them, and things improved after that. And it was just because it just had copious amounts of sputum, just couldn't clear what was coming up. And obviously it'd be very easy to just say, well, don't seem to be getting any better, let's send them back in. Well, patients want to be staying at home, they want to be in their own environment, so it's our job really to try and do as much as we can to keep them where they are. So are they optimized? You know, in that case, I think we gave the patient BD saline nebs, and we obviously got the chest physio out to do some exercises with them, and I think we prescribed Nerobica as well, and things improved. And it was purely because of the chest clearance situation. It wasn't that they were more unwell or needed to go back into hospital, but very easily that could have been someone that ended up back in hospital.
I always think for me, the worrying side of it is when you've got those patients that really don't want to go back in the hospital, but you know they should be there. That's quite scary at times.
But it is very scary. But then again, there are a lot of people like that now, and they don't want to go back in. And I think as long as the risks have been discussed with that patient, and you know that the outcome could be that they end up very, very unwell or even death. I think as long as you're open with that and they're happy and they understand the risks that are involved with that, kind of guidelines a little bit at that point end up going out the window, because you
Yeah.
can't stick to them because it doesn't make sense. It doesn't fit the
No.
guideline picture, because the guideline picture 3 steps ago, they would have been hospital.
Yeah.
So you just have to, it, again, is massive symptom management. Give them everything you can in terms of optimal treatment in the community. Can we get community IVs? You know, what can we give in the community that keeps that patient there, and obviously keeps their wishes
Yeah.
forefront, really. And it is scary, but like I say, documentation is your friend. Document everything. We have refusal of admission forms, we get them signed, we get them witnessed by somebody, so that you've really covered your own back, that, you know, you've given them every option to go into hospital. They don't want that treatment, so, you know, the guidelines might not say at that point you need a chest x-ray, but you might do a chest x-ray, just because then you've given everything to be able to support the patient. So I think these are the ones that talking with the clinician on call might help, you know, for the virtual ward, and just have that conversation. And we do often have just conversations, and it might not be. I had one last week with a matron, and they weren't appropriate for the virtual ward. By that point, just on 3 of their observations, they were using a 6, so they weren't necessarily somebody that we would be bringing onto the virtual ward, because they'd have been pinging every time they put their obs in, and totally not appropriate. But obviously was able to give some advice and things, and they were able to manage the patient at home. I think the patient's absolutely fine now, but you know, that kind of support, and it supports you guys as well to say that you've escalated it to somebody. You know, when the consultants are on call, it's nice to be able to have a chat with the consultant. And I don't know, you know, I think there was the team there. They've obviously got good links, and they've got their own doctors and things like that attached to the team.
Really,
but not everybody.
Links.
So that's fine if you've got good links, but not every areas in that same situation. Lots of places are advanced clinical practitioner led, and they don't have that ability to do that. So it's about making sure that we support each other, and that we feel supported by escalating it appropriately, and then we get the right advice and put those things in place, really, for individuals in the community. Any other questions?
Can I just ask about the availability of the recording for my colleagues, when it'll be available and where to find it?
Yeah, of course. So hopefully by the end of this week, I'm going to be setting up a SharePoint. I've just got to speak to our IT department just to block them external links and things, so it can go right across Cheshire and Merseyside. Yeah, so hopefully before the end of the week. But I'll keep you updated on that. Okay.
Thank you.
Claire,
yeah,
can you just explain to me, please, because I was just a bit confused about whether the course is 6 weeks every Monday for the next 6 weeks.
So it's not every Monday. It's literally just when consultants can do it. So some consultants are only free on a Friday, some on a Wednesday. So I have got a program. I'll send the rest of it out. But it's
lovely.
Literally, because we're a little bit all over the shop, and it's not like every same day every week. I think it can capture everybody. Do you know what I mean? It's there for everybody to get involved in. But if we record it, then
does it follow on from, like, we've had this like one today? Will there be like 1, 2, 3, 4? So you can sort of, and then it'll repeat itself, and then you just jump on the one that you need to jump on. Is that how it works?
So the main subjects that we're trying to cover across the ARI are community CAP, bronchiectasis, influenza, lower respiratory tract infections. Some people are asking for sepsis, ABG, chest x-rays. So we're going to try and just set up now and try and do one every week right up until the winter pressures start. So right up until end of September, beginning of November.
Wonderful.
And we're going to be having, so Vanessa's done today, and hopefully Vanessa will do a follow-on from today. And then that could be like, you could gain a competency for doing them too. But we've also got some consultants doing community acquired pneumonia, because we want that to be like a massive aspect of it, because it's one of the main things, isn't it, in the community for your winter pressures and stuff. So we're going to concentrate massively on the community acquired pneumonia and COPD as well. So what we'll do is the consultant who's doing COPD will do a couple of sessions, and then you could do that as a competency, because it'll all follow on.
Lovely. I'm just asking because I only do 2 days a week, so I can jump on from home, you see. So
if
I know when it is,
and then with the recordings as well, you can dip in And then if you've got any questions, we can then set up the Q&A workshops with the relevant speaker, and then you'll have half an hour just to ask some questions. And then we are going to try and have some face-to-face workshops as well, dipped in, so that everyone can meet, everyone can you know, integrate and get to know each other and discuss what issues you're having and stuff. So yeah,
lovely. Thanks, Claire.
Okay,
just a
not
quick
a problem.
one, Claire, sorry, in regards to the competencies, do you think it's enough for to sort of say for that
you're
session for somebody
competent?
I don't think it is.
Yeah, no. So what we're going to be doing is, I've spoke to Sarah Sibley about this, who is the lead. So what we're going to hopefully do is, everybody should be attending as many sessions as they can, dip in and dip out of the recordings, and then with the backing of your line manager, you will then say when you feel competent. So if you've got to watch 15 weeks worth of sessions, then that's up to you. We're going to sort of make it like individual responsibility, as well as we're going to provide you all the information, and then obviously you can deem when you feel competent.
Right.
I think on that as well. Sorry, I don't know your name. But
Miriam.
Miriam. On that basis, I think you know yourself. If you're not feeling happy with a certain subject, then you could maybe ask and request, you know, for some more training to be put into this virtual ward series, but so that it's then covered again in a different way by a different person. And you know, I feel much happier doing face-to-face type training. This, you know, it's a means to an end, and it gets lots of people together from a very, you know, we can see today from Crewe, from Leighton, from Sefton, from Liverpool. We've got, you know, Chester. We've got a group from a big cohort. You wouldn't, that'd cost a lot of money, a lot of time, a lot of effort to get those people face to face. But it might be that we can maybe get the clinician on call to go round and actually do ones in your area. You know, if you've got enough in a certain area, if you feel like that's more supportive or that's helpful for your team, we could hopefully then try and arrange that to come to you and do more scenario based, which I think is better. My scenarios, unfortunately, I don't know what's happened, they've dropped off the slides. But I think that's the better viewpoint where you do that, because that's what you do in practice, and that's kind of where we want to say, okay, so is this patient going to be safe? You know, what do we need to do now? This is what your result says. Now what would you do? So they've had the chest x-ray, the chest x-rays come back looking like this. Now what would you do? And I think walking people through those steps is a lot more competency based than just telling somebody you can read these guidelines inside out, but it's about how do you interpret them and how do you put them into practice. And you know, I try not to put them all in the slides, because I feel like it just goes whew, you know, especially with certain points, the antimicrobial and the pathophysiology. If you start going into it in depth, it really does go over a lot of people's heads, and it's trying to make that fit every level that we've got on the call. So it's quite hard. But if you know that you've got a group of AMPs in an area, or ACPs or band 6s that all want something, you know, similar, we can maybe target it a bit better.
And after this session today, I will be sending out like a QR code for feedback, because feedback will give us some direction as well as to what you need. So when we're doing the face-to-face sessions, if there are, you know, if you do want to, I don't know, do a clinical skill on ABG to gain your competency, we can do that in a workshop face-to-face. You know, it's feedback will direct some of the sessions as well. So definitely try and do the feedback, scan the QR code and do that as well.
Yeah, I think from a virtual ward point of view, it's obviously you've got the specialist, haven't you, the specialist respiratory team. So from a nursing point of view, we're obviously dealing with not just respiratory but everything, aren't we? So you sort of look at it a little bit differently, I think, than so I think from my point of view, it's knowing them targets to look for, isn't it? Using your CURB and them sorts of things, really, that's really important for us. And having that backup as well from the ACPs is really important to run it by.
Yeah, well, that's massive. So there's obviously MD calculator. You can get the actual CURB as a score on your apps on your phone. So if you wanted just to do a quick score and you knew somebody's background, you could quickly pop it in and it will come out very clearly with a score. And then that score, it just kind of can kick you into gear, you know, if it comes back and it's a lot higher than you expected, and it just kind of focuses your treatment, and okay, now I need to escalate this patient because actually they're scoring this, and that's indicating potentially a hospital admission.
Yeah. So what's that app?
So MD Calculate, so it does all sorts. So that has like Wells score on it, loads of other, CHAD-VASC, all different scores for very quick, assessments in the community for people that are unwell, for lots of just risk score basically.
Lovely, thank you.
Okay, yeah. All right, fab. Thank you, Vanessa.
No problem. Thanks very much.
All right, I'm going to stop recording now. Okay, for everybody. Okay.